So what we're going to do now is run till about 12:15. Sorry to keep going back and forth, East Coast, West Coast. 12:15 your time as we discuss further. This is a chance for CTAF in taking votes to also, again, reflect on the comments made by patients and others. We have our patient experts, Gwen and Lisa, still with us, in addition to the clinical experts. So let's go ahead and dive in and move to the first voting question. All right, to be clear, for the patient population under consideration, it is adults with symptomatic hypertrophic obstructive cardiomyopathy. I see we continue to go back and forth ourselves between HCM and HOCM, much to Lisa's point, but I think we know what we're talking about. And these are patients who are on background therapy with beta blockers and or calcium channel blockers. So can we advance to the next slide? Okay, the first voting question is the currently available evidence adequate to demonstrate that the net health benefit of adding Mavacamten to background therapy is superior to that provided by background therapy alone? And Jason, can I start by inviting you to just really briefly summarize again for the CTAF panel, the rationale, the thinking of the ICER research team, pointing to any key tables in the evidence summary document, and again, summarizing the evidence rating that was given?
Yeah, no, thank you, Steve. Yeah, so our assessment of this is that the most informative data to answer this question comes from the Explorer trial. And just to remind, the Explorer trial demonstrated improvements for Mavacamten relative to background therapy, again, defined as beta blockers and calcium channel blockers by several different metrics. So NYHA class, it's clinician, it is subjective, but it is a clinician assessed clinical endpoint, but there were also more objective endpoints like peak VO2, and importantly, there were patient-reported outcomes through the KCCQ. The magnitude, so there was a statistically significant difference, but it was also a meaningful magnitude. The magnitude was large and above the clinically important difference. So in your evidence summary, a lot of this appears in table 3, I believe. I'll also add that I think the evidence rating, just, I know this has been addressed, but this is really critically important in the evidence rating. The reason why we didn't give it, so this is a well-done trial, lots of endpoints. Why didn't we say it's probably superior and it's just with the P/I? The issue really is around this ejection fraction uncertainty. So we're sort of, I recognize after thinking about this for 6 or 7 months that I'm sort of punting to the voting panel in a sense. This was a very well-done trial. We think, endpoints that are clearly different in the two treatment groups, but there's some uncertainty about long-term safety. I mean, I will say, just since Dr. Wang from the company kind of raised it, we think that any notion that Mavacamten has a mortality benefit is really profoundly speculative at this point. I think there's sort of basic kind of getting mixed up between causation and correlation in terms of just because a drug improves your NYJ class doesn't mean, and in the real world, that's associated with a different mortality doesn't mean that the drug reduces mortality.
All right. I see that we already have some questions. Feel free to use your hand. It's probably the best way to catch my eye. And we will start off with some questions and comments, remembering that we also have, again, the patient experts and the clinical experts available to us. Rita?
Thanks very much. I do have a question, but just to add to what Jason just said, and I believe the trial also showed there was no correlation between, or the other trials, New York Heart Association class and mortality. And I do think the mechanisms are different because the functional class, I think, is more related to obstruction, and the mortality is unfortunately very hard to predict because of our general inability to predict who's going to have sudden death. But my question, or really comment, was that I will just note, as a researcher and as an editor, I find it disturbing when trials like the Explorer trial say things like both the authors and employees of the sponsor participated in data analysis, and that I note both statisticians for the Explorer trial were employed by the company that makes the drug. all for industry-funded research, but I think that the researchers have to be independent of financial conflict. And when you have the company directly involved in data analysis, in the trial, in the writing, and the statistical analysis, I think it introduces bias that doesn't need to be there. And I, there for that reason, have a lot of concerns about this trial and this kind of funding mechanism.
Okay, thanks. Milland, I hope you guys don't mind if I slip in the first name. It's not for lack of respect. Milland, please go ahead.
Perfect. Thank you. So a couple of points. One is, specifically to this question, I think what Jason has said, I completely agree with. So, but to clarify a couple of important things for the panel. In Explorer, these were predominantly NYHA class 2 patients, and these patients by study design would only a small proportion would have met criteria for SRT because they were mostly NYHA class 2 patients. Number one, so this is not a surgical population or an SRT population, sorry. The second thing is in Explorer specifically, disopyramide was not as part of therapy. So this is pretty much talking about beta blocker, calcium channel blocker. Correct. So these are two crucial points. And the third, Rita's point is very well taken, I think. And again, I was not involved with the Explorer study, but to Rita's point, the Valor study that is ongoing, it is run out of where there is independent academic research organization, C5 Research, based in Cleveland Clinic, Cleveland, Ohio, that is running the analysis independently, and the company may or will run their own analysis. So the same drug for the additional trial is being run according to what Rita insinuated should be run. Thanks
very much. Okay, Joy, and then Elizabeth, and we'll see if we have any after that. Joy.
So I'm sort of a concrete person, and I'm looking at this question, and it says, is currently available evidence adequate to demonstrate that the net health benefit? So I guess the first thing that comes into my mind is net health benefit over what time period? Because we have a 30-week trial. It seems like this medication probably made people feel substantially better in that 30 weeks, but there are a lot of questions about long-term benefit and adverse effects that are unanswered. And it seems as if this medication would potentially be a lifelong use type of drug. So is this question like net health benefit over a lifetime, or is it net health benefit over a year?
You want the easy answer? It's both. This is why this is difficult. Obviously, every drug near the time of FDA approval, we're going to have relatively short-term data on it. And the reason that you guys are asked to kind of consider the longer term as well is because to a certain extent, that's what patients and doctors and payers are going to be thinking about as well. Is the evidence in your mind with the uncertainty around both the benefits and their duration and the safety and its duration? Again, sometimes the safety can be a bigger deal because of a mechanism of action. Some people intuitively give a new mechanism of action more long-term unknown risks, but others don't. So there's no right answer, but I would generally say that most people in answering this question would look at some larger view than whatever just the short-term data are, factoring in other ways to try to judge what the risks might be and benefits longer term. All right, let me try to go around. I do have to be a little bit careful with our time this time because we don't want to run past our benchmark here. So I'm going to try to be quick. And if you guys can help me out with that, I'd appreciate it. Liz?
Yeah, and again, it's the same theme, but I'll try and kind of bring up some other concepts around it. As I said before, there are other instances where doing something that intuitively you think is bad, like reducing kidney function long-term is good for the kidney. But we have data on that before we kind of decide about things. And in this particular instance, clearly in the very short term, it seems like this drug is good, but given its mechanism of action, I think you could have anticipated it was going to reduce ejection fraction. And I'm wondering why the time frame was set up like this and why the FDA didn't consider it important to wait longer. We've all seen instances where we think new drugs are great and then later discover the very negative adverse long-term effects and feel badly about having prescribed these drugs or used them. And I think that's what everyone is expressing here is our concern that we would in the long term cause permanent cardiac harm for using these drugs when we don't have adequate data to know if it's safe. But was there any consideration for the FDA? Does anyone know of a longer trial so that we could address this?
Jason, do you want to address that quickly?
Sure. Yeah. I mean, I first of all want to say, Dr. Murphy and the others, I think you're getting at exactly the right issues in terms of making these decisions. I don't have insight into the specific FDA decision-making process, but I will say that the long-term extension study, Mavacamten, is planned for 5 years. So my anticipation, I would say, is that this will be resolved one way or the other, in part through those data and potentially through post-marketing surveillance. But I will say that, as you've articulated, I think we've heard from different people today, there is a lot of speculation and uncertainty about either direction, right? So the companies coming here saying, oh, well, look at this cardiac MRI results, it's actually going to potentially reduce mortality. I think that's speculative. I think that's really on shaky ground. But on the other hand, you have a concern about harm. So I do think, without solving this problem, I do think there's substantial uncertainty around the time horizon. I do anticipate that Mavacamten will provide evidence towards this because it's going to be 5 years.
Okay, thanks. Lisa, please go ahead.
Very quickly, I just want to clarify, and of course, Marty, Malin, jump in on this if you feel it's needed. Ejection fractions in HCM tend to be supernormal because we have a very thick, stiff heart that beats very hard. So minor changes in ejection fraction, while they may be very problematic in other populations, have a slightly different meaning here. When you see these very large drops in EF, well, that is concerning to all of us. And we do know that we need a lot more time and trial, but I'm begging you not to lose the opportunity for patients who've never had a labeled indication drug before, triggering towards mechanism of action for the disease, to let us try. We need to try. There's something in the HCM guidelines called shared decision making. And the risk and the benefit of a drug like Mavacamten to a patient has to be viewed in the context of that individual patient. I know you're looking for global economic impact, but we've never had a drug for us, and we're using other people's drugs that we've never really tried in HCM. There is no great data on mechanism for beta blockers and calcium channel blockers to make any long-term potential benefit to us. This is the first time we're entering a class of drugs that are targeting our anatomy. And I'm just asking you to be cautious before you're too quick to say, oh, we don't know enough yet. I couldn't agree more. I think this review is a little bit early, but this is what we have to deal with. And this is our reality today. So please vote carefully.
We talked with our panel, by the way, it's always hard to pull the two apart, but in a sense, we are asking them to vote on the evidence and not on whether it should or shouldn't be covered. We'll talk about it in the policy roundtable, but if the FDA approves it, it's going to be covered. And we'll talk about under what circumstances, I guess. But I hear what you're saying, but I think to a certain extent, they are trying to view this as an evidence question and not as a coverage question. Bob, I'm going to give you one quick shot, then we got to move on.
I think all of my fellow panel members know me to be a pretty hardcore RCT believer. However, this question appears to me to be rather straightforward at this particular point in time. If I was sitting on the FDA advisory panel, I'm voting to approve this. So this is a yes, just straightforwardly.
Okay. Thank you. All right, let's go ahead and make sure that I think everybody has access to the poll. I see a couple votes already being entered. We should have 15, unless something has happened in that 5-minute break, we should have 15 votes. So let's go ahead and wait till we see 15 and then we'll reveal the results. Getting there, 2 more. If anybody on CTAF is having technical issues, Don't be shy, let us know so that we can at least move on if we have to, but we're almost there. Okay, let's see the results. Okay, 6 yes and 9 no. Let's go to the next question. All right, is the currently available evidence adequate to demonstrate that the net health benefit of Mavacamten is superior to that provided by disopyramide? Jason, I'll pitch it back to you again for a quick, really quick summary, please.
Sure. Yeah. So again, no trial. So we're kind of looking at a retrospective analysis of disopyramide that has multiple sources of bias, potential relatively modest effect estimate with potential because of the study designed to actually exaggerate versus the data from Mavacamten, which we've already discussed in Explorer. These are not compared head to head. The relevant table is table 6 to get data on disopyramide.
All right. CTAF, please dive in. It is helpful, like Bob did, if someone feels like they're going to be voting yes, please go ahead and say why you think and let your co-panelists hear that. And someone who is thinking of potentially voting no, doing the same, hearing different perspectives is always helpful. Any questions or thoughts on this vote? Lisa is shaking her head like she either wants to have a comment or was responding to somebody offline. I don't know which it was. Did you want to say something?
I have a problem with this question. It's not been studied in any real way. You're looking at retrospective data on disopyramide, which is really not diso. It's really Norpace controlled release. And I'm sorry to those who have to vote on this because I don't think you have evidence to vote on this question.
But the question says, is there currently available evidence? So I think the answer is no, there isn't currently available evidence.
Yeah, and I almost feel like putting an asterisk or a parenthesis in every question saying provided by disopyramide, which is not available to patients in the US, right? So we're not going to avoid that issue, and then we'll come back in the PRT. Okay, why don't we? Oh, Paul, please go ahead.
Oh, just that I was going to say, right. Question that also does bother me. It sort of implies that disopyramide is clearly a recommended therapy with evidence behind it, and I think that as displayed today, the evidence is incredibly weak.
It is. I mean, I am a follower to this process. I wasn't part of the team. It is part of the guidelines, though, as a treatment option, right?
Yeah, I won't comment on my view on that class 1 recommendation, but I agree with the data presented today.
All right, but you just we brought that up.
This is Ralph. Right. I actually feel the same way as Paul. I'm thinking about as a clinician, and it's really hard to get, independent of getting it from the pharmacy, it's hard to get patients who want to take this disopyramide, and the evidence is pretty weak that we have, again, not head to head. And I could see myself being in the same situation, certainly prescribing Mavacamten, yet, we don't have the evidence.
All right, let's go. I want to give Martin a quick chance, and then I think we may be beating a dead horse, so to speak. So we'll see. Martin?
I just want to say, just for a little balance there, I'm not sure I completely agree with some of those thoughts. Look, independent of the availability issue, which my understanding is going to improve here, but independent of that, and of course, independent of what we've already said is the limitation, we don't have head-to-head comparisons, but we do again have, several decade experience among expert centers with the drug. Okay. And again, the published data is limited, but we have a lot of experience with this drug. And that experience is good. Okay. It's very good. And it mimics the published experience as well. Okay. So I think we can put weight on what's published in terms of disopyramide efficacy and safety for that reason. And that is the reason why it got elevated in the guidelines the way it did in terms of a priority, in terms of management consideration. So I just want to make sure we're balanced in that.
All right. Well, the vote, by the way, it's hard to tease this out too, but the vote is not about whether the evidence is adequate to say that disopyramide works. It's kind of like taking the uncertainty around that and comparing it to the uncertainty around Mavacamten, do we have the ability to distinguish the two and say that Mavacamten is better? So I'm going to just go ahead and suggest that we go ahead and vote on this so that we have time to talk about the important other benefits and contextual issues. Please go ahead and vote. All right. Oops, I think you saw in a flash there. Okay, 2 yes and 13 no. If we have time, we might come back to debrief that, but 13 no, 2 yes. Let's keep going. All right, we enter a different realm here. The CTAF panel is familiar with the framing of these questions. For the public and folks kind of participating for the first time, the general intent is to recognize that not everything that matters has been counted or can be counted in a specific way, but may still be important. And we want to think about the way that different people will weigh this in ultimate decisions around a fair price or around coverage and those kinds of things. So and anytime a condition is as heterogeneous as HCM is, it creates difficulties, but in a sense, we are still talking a little bit about the average, if you will, as these things are considered. But here it is important for people to remember the spread and the variety of experience and of symptomatology, et cetera. So let's go ahead and launch in. The first two questions are about making judgments of overall long-term value for money. And we ask kind of what is the relative priority that should be given to any effective treatment for HOCM on the basis of two following contextual considerations. And this really does mean that we're not saying, do you think Mavacamten works or not? We're not saying, is it a lot better or a little bit better? We're saying, what about HOCM as a condition? Given the existing today treatment options, what do we think about the priority for treating for any treatment based on the following two contextual considerations? First, the acuity of the need for treatment of individual patients based on their short-term risk of death or progression to permanent disability. So again, this is a little bit wordy, but it's basically capturing the idea that sometimes patients with a condition like pancreatic cancer might have very little time left to live, and even a little bit of time added on to that can seem more important on an average basis. I think we jumped the gun there a little bit, so let's hold off on the voting. We might have to go back anyway. So in this case, we're talking about, do we put a very low priority on this based on the acuity of need for HOCM, or a very high priority based on its acuity of need for treatment? Let me invite, let's see, this is tough because I know the clinical experts aren't as familiar with this language. Maybe I can invite one of our current CTAF panelists, whether they're cardiologists or not. As you see this, as you think through it, how do you view your thinking about HOCM as a condition in this issue? All right.
I think as has been said by a lot of the panelists, HOCM is a very heterogeneous disease, and some people go many years and without progression, and some people will progress more quickly, as we heard today. So I think it's quite heterogeneous.
And I would agree with Rita. You know, Steve, you said we need to consider that it's heterogeneous, but we need to consider here, what is the average? And that's really hard to do because we know patients are out there who are suffering, but you know, we have to think on the average.
Well, again, you guys get the unenviable task of doing both, because it can be that the heterogeneity is so substantial that from a values or an ethical perspective, you wanted to overweigh the average. And that's, you know, if we had Benadryl can be life-saving, or it can treat everybody's, you know, seasonal allergies. So in a sense, we have to kind of deal with that tension here very much more, I would say. Gwen, thank you. What would you like to say?
Just a couple of points. This is a complicated question, but as a patient perspective, a couple of things. First of all, this is a lifetime condition, and due to technologies, genetic testing, please take into consideration that individuals are being diagnosed earlier and earlier in life and accurately diagnosed. So in Kinsbury's case, 3 out of 6 children, knowing what is going to be an adequate treatment choice for them in the context of their entire life decisions, then those issues are very important. They should have a high priority. That is a long lifetime. This is not a condition that has a cure in a traditional sense. So patients that are identified now are facing multitude of contextual consideration, lifetime choices, employment decisions, disability, whether to remain married, whether to have children. So if I understand this question correctly, all of those are always going to have a high priority because that's where we as patients live. We live outside of the hospital. We live outside of the doctor's office. And those questions and those nuances, while they may be extraordinarily variable, have an extraordinarily high importance to every patient.
Thank you. Actually, you anticipated, you probably didn't know, I'm sure, but you anticipated at least a couple of the other voting questions coming up. And the next one actually is about the magnitude of the lifetime burden. So this one is meant to capture a more short-term timeline, but what you've said is going to be helpful for the panel as they think through several of the votes to come. Alex, please.
Quick point of clarification. For these questions 3 and 4, should we consider symptomatic HOCM or asymptomatic and undiagnosed HOCM as well?
I think symptomatic HOCM would make more sense.
Symptomatic HOCM, as in questions 1 and 2.
Correct.
Thanks.
Martin, I saw your hand up? Yes.
Yeah, I just want to be clear about this because it's really, really important. In terms of answering the specific question here, there's a lot of evidence about this in terms of natural history. When you're talking about short term with symptomatic obstructive HCM, risk of death or mortality is incredibly low, as it is with the disease as a whole. You know, you're talking about a 0.5% per year mortality rate with HCM. Very, very low. It needs to be lower, but it's very low lifetime. And so any kind of framing of acute risk of death would have to be considered to be low, very low priority, as would progression of symptoms, which often occur for the vast majority of patients more slowly over time rather than acutely.
Got it. Okay, let's go ahead and vote, and then we'll get to the magnitude of the lifetime burden quickly after that and the other potential benefits. Apologies, I have to come so close to the screen to read the numbers of votes. One more, it looks like. There we go. Okay, so we have 7 as average, we have 3 high, 3 low, and 2 very low. All right, let's go to the next question, which is, again, in line with what Gwen was talking about. Now we're talking about, does it have a relative priority linked to its magnitude of the lifetime impact on individuals of the condition being treated? This is sometimes meant to capture a different kind of priority we might give to something that has no effect on mortality, but throughout the life course of patients. Something like, well, multiple sclerosis does have a mortality effect as well, but something that has a burden over many years or decades and therefore should have a special priority. Would any of the clinical experts or Lisa, because Gwen in a sense already addressed this, would you like to add anything more to your comments on this before the panel votes? Milan, yes.
So yeah, I think, pertaining to both the questions in general, there's going to be different strokes for different folks here. The connotation in a gene positive, phenotype negative person who may never develop HCM, like phenotypic HCM, is going to be different from somebody like Lisa, who we heard her incredible journey, or some of our other patient advocates that we heard. So again, it is going to be the priority, the lifetime impact is going to be very different depending upon who we are talking about.
Right. Understood. Thank you. Lisa.
I'm going to piggyback on what Malin just said there, that this is a very diverse patient population. I think we beat that dead horse pretty well today. But the impact on life, if I were to have had the opportunity to treat my HCM with something that would have reduced my obstruction in my late teens, early 20s, I might have avoided endocarditis because the obstruction led to my endocarditis and my stroke. So the cascade problems related to HCM and the consequences of obstruction are not just measured in New York Heart Association class. There are other risks associated with life with obstructive HCM. In Gwen's case, we're dealing with her left atrial dimension has gotten larger because there's this back pressure from the ventricle. So if we could have treated her earlier, could she have avoided atrial fibrillation? These are the promises that we're looking at here out of this class of drug. I know it's still early. I know we have a long way to go, and I'm looking forward to the phase 4 more than probably any of you are, because we need to understand its value. But the potential that has been shown in these early studies show us so much promise, and we want to make sure that people have an opportunity to get early treatment to avoid long-term consequences. Marty, maybe you want to comment more on that?
No, I mean, the only comment I'll say, and I'll be very brief, is just that, you know, again, in terms of this question for this initiative, which is Mavacamten in its treatment of symptomatic obstructive HCM, again, we're not talking about mortality here because that's really low. The priority is about progression of symptoms, the symptom progression that impacts quality of life. And that, that's what we're talking about. And that magnitude does increase over time for patients with obstructive HCM, that's symptomatic burden. And so treatments that can help reverse that, or other options that can address that, is the issue here. So that's the priority.
Thank you. Thank you. That's all very helpful. All right, let's go ahead and vote on this question. Again, make sure you've got the scaling right here. A is very low priority, E is very high. Okay. All right, so we've got 4 average, 10 high, and 1 very high. All right, thanks. Okay, we're going into a series now of 6 questions about what we sometimes call benefits beyond health or other potential benefits. And these are things, again, that in some ways are captured by the clinical data in some cases, but may not be. And so you'll see the 6 questions will flow pretty quickly. And I think they've been informed extremely well by the patient testimony and comments that we had earlier today, but we'll still try to take a pit stop if we feel like we should add further context to that. So the questions are, what are the effects? And here we are thinking about Mavacamten specifically and its relative effects. So if you think that Mavacamten makes a big difference, then you would, in a sense, think larger on the potential other benefits. If you think that it has very small or none, then that would affect your votes. So this is about Mavacamten and the following potential outcomes as a part of thinking about the overall long-term value for money. Next. First is patients' ability to achieve their major life goals related to education, work, or family life. So again, thinking about this as it does stretch out over the years and what we've heard before, do you think Mavacamten provides, in terms of this, you could almost call it a spillover or a broader effect, anything from a major negative effect on these things to a major positive effect? I almost feel duty bound to let Lisa and Gwen hammer that nail again. You guys have done a great job, and I think you've made it very helpfully clear to everybody. Is there anything else you'd like to say?
I think I've made my point pretty clear today that I'm in support of putting the option, the tool in the toolbox of patients to choose this so that they can reach their life goals, education, work, family, and balance. I think this is a major positive effect in my opinion, but Gwen, why don't you chime in?
Just to put a little color to the testimony, as I mentioned, every aspect of my life has been affected by HCM. And so I consider any therapy, new medication, treatment that provides me a positive effect or elimination of symptoms, a longer life. My life expectancy was 50. I am now 65. Okay. And so I feel that I am extraordinarily fortunate. And I am fortunate because of the research and the innovation by the many clinicians and the patients that have put themselves out there in the face of unknown. And that's where we are again. What makes this different is we are finally getting at the root cause of this condition. And we have a company that is willing to take that on. So I see, again, my education, I could never get health insurance. I have lied, I've committed insurance fraud, I've skipped doctor's appointments. I've done all kinds of crazy things, if you want to read all my public testimony, simply to have health insurance. I was never insurable until the passage of the Affordable Care Act. And even now, just this week, I had a financial planner say to me that I should take Social Security benefits as soon as possible because of my heart condition and the uncertainty of my future. The very next day, I had an orthodontist tell me that even though I need jaw surgery to prevent the obstruction, airway obstruction, which is likely causing my AFib, that because of your heart condition and your age, I cannot ethically condone doing this. So every day, not just when I was in school or actively employed, does this condition have some ripple effect on my life?
Great, thank you. Say, brief, I hope.
Yeah, I guess I was just going to say, I really hate this question for this medication, specifically because I think, as has been mentioned previously, I feel like the short-term effects are beneficial. And I think the evidence is, I felt like the evidence was clear. I think the problem here is that major life goals really, in my mind, point to the long-term effects. And I feel like we have both plausible reasons to suggest that maybe long-term effects would be good because you could potentially have, decreased, remodeling effects and speculative questions about whether there's even mortality benefits. And there's also potential reasons why the mechanism would suggest that you could actually lead to permanent reductions in EF, which actually could lead to, so I have just this huge wide range of what the long-term effects are. And so it feels really difficult for me to say what answer would be well-informed. It's very hard. So I hate this question. I just wanted to let you know I hate this.
No, I think that's not a good perspective. In other words, if I may paraphrase, if the short-term effects pan out over the long haul without any risks, then you might say it would have a major positive effect. If it turns out to be a wash, then maybe it's no difference. And so it's a hard vote to take, even though you recognize that the potential for it to have a beneficial effect on patients' broader kind of life goals is definitely there. All right. Lisa, you get the last word, I'm afraid, and then we're going to have to keep moving because we've got other potential benefits.
I'm going to be really brief here. I'm going to say that patients' ability to achieve major life goals, I want you to think of that not necessarily as the long-term 20-year outcome. Somebody may want to get through their child's early years so that they don't have to have a myectomy and worry about picking their child up and putting him in a crib. We might build 2-3 years out before they have to go for an intervention. Somebody may want to finish a college degree. Somebody may be going for an improvement in their work situation and they want stability during that time in their life. Whether it be for a year, 3 years, or 5 years, that's up to the patient to choose when they're willing to take the risk of surgery. But we don't want them putting off therapy to reduce obstruction because they're waiting for that milestone moment in their life. I want them to have the opportunity to take action and minimize their risk, minimize their long-term complication risks with a short-term solution, even if that's a year, 2 years, or 10 years. We don't know yet. So I caution you to think of real life goals and not full lifetimes of goals.
Okay. Good perspective. Okay, everybody, let's go ahead and vote on this question, please. Joanna, forgive me if that's put a crimp on your comment. Hopefully we'll have time to come back and deal with it later. Okay. The answer is, we have 1 minor negative, 1 no difference, 11 minor positive, and 2 major positive. All right, let's keep going. I think we can probably cover the next one with maybe a little bit less conversation. We'll see, because there are a couple that I think will take more conversation. This one is the same question, but about caregivers. So we did hear from both Lisa and I forget one of the other, at least patient testimonies talked about the role on the family, the burden on the family to, cart people around and to have to kind of help care for them in different ways. So knowing what you do and thinking what you do about Mavacamten, what do you think of its effect will be on caregivers' quality of life and or their ability to achieve their major goals? Any questions from CTAF about how you should think this through or anything else? If not, let's go ahead and vote. Okay, just waiting for one more. Okay, everybody check your phone or a laptop or iPad just to see if it's lit up, because we may have to move forward if we don't get that one more vote in a sec. Okay, let's keep going. Unfortunately, we're just going to have to count this on a, on a numerator of 14. Let's go ahead. Denominator, I mean. Okay, we did get 15 right at the end. Thanks. So we have, one minor negative, 2 average. This looks very similar to the last one, 11 minor positive and 1 major positive. Okay, next question. Okay, a little bit trickier one. This question is meant to capture situations in which drugs may help address, by their positive effects, help address our goal of reducing health inequities between races, between ages, or how, people can frame this in different ways about inequity. And so this is scaled again from major negative effect to major positive effect. And again, I guess we could start off if either the clinical, oh good, we've got some hands up already. I'd love to hear your thoughts on this. Milind, why don't we start with you?
Yeah, so yes, I think this is important, and I will be talking about this in my public testimony also. We have great myectomy programs, but there ain't enough of those. So what we heard from the Reverend, the pastor, about his 9-hour drive, or from the lawyer about almost losing, not almost losing their jobs, etc., is what we need is to expand the pie of available options. And a drug like this, this is not going to take away from any procedure that is out there, any drug that is out there. This is adding, this is expanding the pie. This is, I can tell you as a clinician, scientist, whatever, I am, as a hokumologist, one of the best things that has happened today is this significant emphasis on educating the community of primary care providers, primary cardiologists, expanding the centers of excellence. So this is, to me, this has already achieved its purpose of expanding the pie. The key here is, people talk about healthcare equalities as based on gender and race. It is also transportation, availability, distance to a program, what have you. So I think that's what I'm going to say.
Good. I will, in some ways, I feel like we should make sure in the future to have you all be able to see the voting questions and realize what's coming next. The next voting question is on opportunity to improve access to treatment. So we kind of had this split out from that one. It doesn't hurt to double count it in, because the way you're thinking about it is definitely around access. Now, I know some other people may want to comment on whether the availability of Mavacamten will really change that. And we may capture some of that in the policy roundtable as well, but I appreciate your comment. I'm going to try to go very quickly. I apologize because of our time constraints, but Lisa, go ahead, and then I'll go to Jason.
Very quickly so we can get other comments in. There are patients who have health inequities, not necessarily ones that you would think of on the front end of this. I have patients who have religious beliefs that make surgery very unattainable to them. There are societal issues that they're waiting for an elder in the family to make a decision whether they can have surgery because it's invasive. and expensive or time consuming. To give patients an access to an oral agent that can address obstruction in those communities are really important, and they're very often not heard from. Additionally, I think through telemedicine with centers of excellence guiding, we'll be able to get to more rural populations with maybe these types of oral opportunities for treatment, not only in the United States, but around the world. So I think there's a lot of societal goal reaching here to remove some of the inequities and access to treatment for obstruction specifically.
Thank you. Saley, go ahead.
I mean, so I guess I wanted to kind of say that I do think that this medication, like other therapies for other medications for other diseases that we've discussed, has the potential to decrease disparities. The thing that I worry about, and I think has been the recent history, is that the cost actually has a tendency to exacerbate disparities. That the cost makes it so that the people who are most likely to have the financial resources, have insurance, are actually more likely to have access to the newer therapies. And so I agree with the idea that there's a tremendous potential here because this is an oral therapy to decrease health inequities. But I worry that given we know so little about what the cost is going to be, but what the trend has been is for any sort of new therapy to be at a point that where the it really becomes very cost prohibitive. And especially the fact that the trial was actually was 90% white makes me feel like I don't know the level of commitment that the pharmaceutical company in this case has on ensuring widespread accessibility.
All right, Jason, and then we will move to a vote. Remembering that there are, and this is difficult, I'll note again, there's this question on health inequities, and then there is a separate question on opportunity to improve access. It doesn't, they can conflate a little bit, and that's not a problem, but just so you guys know that the two are coming. Jason, go ahead.
Yeah, sorry, I put my head down because I didn't want to waste time. I just want to say this. I want to say one really important thing about this is that as you have heard, it is incredibly clear that this issue around access to centers of excellence, both in terms of the question you're about to vote on and the next one, is critically important to this page. We heard this over and over in the review. I think the one thing that's tricky about Mavacamten, though, and we heard this in the review as well, it is far from clear that Mavacamten is going to be prescribed in the community, which is to say that the same problems with access to these highly specialized centers where you really have deep expertise specifically for HOCM, it's not in general cardiology, this same problem potentially may exist for Mavacamten as well. And then, telemedicine may attenuate that to some extent, but there are a lot of regulation barriers on telemedicine, especially state to state. So it's not clear that Mavacamten is going to provide more access from that perspective than the procedures.
All right. This vote will be taken, and then we were going to talk about this because this is a big deal, just as you said, and as Lisa said. All right, please go ahead and vote on Mavacamten's relative effectiveness and its ability to address society's goal of reducing health inequities. The next vote, I think we're going to take immediately afterwards on access, because that's what we've been talking about. All right, looks like we're at 15. Nope. Yes. Go ahead. All right, 8 no difference, 1 minor negative, 5 minor positive, and 1 major positive. Okay, let's go to the next question. And with your agreement, let's go ahead and vote on opportunity to improve access to treatment. Please go ahead and vote. Almost, it feels like we've got a hanging Chad again. There we go, 15. All right, 6 no difference, 8 minor positive, 1 major positive. Great, one last question before we break for lunch. Okay, so this may seem like it's a perfect fit for Mavacamten, and in a sense, it is, because in some ways we want to make sure that even if the clinical outcomes are judged inseparable between two options, they may have really very different timing or types of risks and benefits that when you sum them all up, it all looks kind of about the same, but that are so different that it offers a value to patients and the system to have these two options. So here we're talking about Mavacamten versus procedural and surgical options. I honestly don't think you guys need to hear more about the fact that surgery is a one-time thing and it has certain risks and benefits, and Mavacamten is a chronic treatment and it has certain known short-term risks and benefits and perceived or projected longer-term outcomes. So I'm going to see if anybody has a burning desire to make a comment on this one, but I think you can see why it was included in this set of questions. All right, let's go ahead and vote. Great, let's see the results. Oops, almost there, sorry. One more, there we go. Okay, 1 no difference, 9 minor positive, and 5 major positive. Okay, and again, these questions are complicated in many ways by the fact that if a panel member believes that the evidence isn't adequate to show that the drug really works, they may say that this is an important issue, but I don't know that the drug really works, and so I can't give it a major positive. So I know it's always hard when we've got two different things going on in a response like this, but it's so far been the best way we can find to capture these kinds of things. So these will be noted in the ICER report and in our press releases because these are important. They also really do tee us up for some of the elements of our discussion in the policy roundtable, which is going to start at 1 p.m. Pacific time after we all run or walk to get some lunch and come back. And I'd just like to thank, again, the patient experts and the clinical experts. You will be with us for the policy roundtable, where we will pick up and move forward with some of the very important issues that are on the table. All right, see everybody back at 1 o'clock.